Thank you. And thank you for coming, and thank you to our panelists for taking time out of your busy lives to be with us. So a few things before we get into our panelists. So we, Canada, will become the first G7 country to sell recreational pot on October 17th of this year. Come that time when cannabis is legal in Canada, a host of unknown to the public issues around cannabis public education and awareness will continue to surface. This was addressed when Health Canada held a by-invitation-only partnership symposium on cannabis public education and awareness this past November in Ottawa. Tonight will not be about debating or discussing legalization, as that is a done deal, nor will it be about the medical use of cannabis. There will be, if you had like a friend that couldn't make it this evening or is interested in this topic and would have loved to have seen it, we will, so the entire thing will be taped and posted on the Manitoba Schizophrenia Society website. All of our panelists agree that the purpose of this evening is most certainly not to bash cannabis users. That's not what this is. Not to shame anyone. That's certainly not the point of this evening. It's not to alarm people or use fear-mongering tactics. It's simply to be healthful and helpful, and it's hopefully a start of a positive conversation. We're not using the word marijuana this evening. It has been used in the past to profile certain groups. We'll use the word cannabis. The Manitoba Schizophrenia Society and all organizations are committed to informed decision-making. So our lives are full of having to make big decisions and choices, and some carry risks, and this is simply to make that journey, that path, a bit smoother. This forum tonight is consistent with the Health Canada website. And again, a big thank you to our panelists for joining us this evening. Like you heard off the top, if you want to get up and you're like, oh, I need to remember what he or she just said, and I want to ask a question about that, but I don't feel comfortable standing up, you can just walk on over, write that down, or jot it down where you're sitting and save it for the break, and all those questions we can get to right after the break. So first up, the medical director at the Addictions Foundation of Manitoba. Please welcome Dr. Jeanette Poulin.
Can everyone hear me well? Can you, a little louder? Is that, yeah, perfect. So I just wanted to first of all thank you all for joining in this important conversation that we're going to be surrounding cannabis. You know, I just want to first of all profess that even from the medical lens as physicians, we're all learning about this topic, and this is something that we will continue to learn as we move forward. And so to me, this is a representation of public, yourselves, wanting to engage in these conversations. And I think it is important because it's happening, and what do we need to know and what do we not need to know, and how do we progress when that landscape is quite confusing. And as I said, there's lots of literature that's out there, lots of statements and claims and companies that are putting things forward, so it can be very confusing for everyone, and I hope that this session tonight will help to enlighten a little bit on this topic. And so I believe we have 10 minutes each to speak, so sometimes that's a feat for me to keep it down to 10 minutes. But I am tasked with sharing some of the trends that we see here in Manitoba in regards to the cannabis use. So if I ask, just by show of hands, how many people think, you know, about 20%, 50%, 70%? What do you think? Is this something that a lot of people are using or not? People have no idea? Yeah. How do you think out in the general population, is this something that a lot of people are engaging in cannabis use? Okay. So we have a 5%, 50%, okay? 60%? 5 million Canadians? Okay, so some excellent guesses here. So we'll move on to our next slide. If we look at some of the trends, here's our kind of Canadian lens on cannabis over from the 1960s to 2015. And importantly, so you see kind of in those percentages, it can be in the initial years about 5 to 10, and it moved on up quickly in the 1970s into higher percentages. And that dotted line on the top and that blue line underneath are actually our youth. That's ages 15 to 17 and 18 to 24. So that's where the largest percentage are consuming cannabis. What I do want to highlight is that the cannabis that was available back in 1960s looked very different than the cannabis in the 1990s, that looked very different in the 2000s, and looks very different today. And what I mean by that is that percentage of THC has changed from, the lower 1% to 3 to 5% back in the early 90s, and then in the mid 2000s we were seeing about 30 to 50% content of THC, and now we're seeing higher than 80%. So it's a completely different product than what was available years ago, and that is an important factor to consider when we're looking at today's literature, when we're looking at those numbers. So here you see, this is again produced by surveys from Health Canada by gender, numbers from 2015 to 2015. And what I'd like to highlight here is that you'll notice, first of all, that consumption of males was higher than females, about 14% in 2013 and 15% in 2015. But what we are noticing is that there's actually an increase in the female gender in consumption of cannabis. And the reason why that's important, this is the Canadian lens, and when I show you very shortly some of our Manitoba numbers, you'll see that we're on par with the national changes. So I'm going to move on to show you some of the provincial statistics. So here for Manitoba, again, what you'll see is that trend that has increased throughout the years from 2013 to 17. In color-coded, those first small light bars are adults, and the youth is in the darker blue. And so again, no different than our national platform, we are seeing the higher consumption in our youth. That 24.3, the reason why it's actually higher in 2014-15, they believe that there might have been some variability in the data collection, so they asked that might not be a full reflection of what we're seeing. So again, that might be an increase, so some variability there. The Manitoba Liquor and Gaming Authority have certainly done some research too, and in surveys, when they discussed with Manitobans, about 21% said that they have used cannabis in the past year. So this is in a general survey I want you to kind of keep in mind. When they asked about the legalization, about another 21% said that they may or will consume cannabis once it's legalized. And then about 56% said that, they had really no intention of starting that. So this is in a general survey. Just to note that 2.3% are at risk for cannabis dependence. And so on average, that's about 1 in 10 of those who consume cannabis may develop that dependence. And when we say dependence, that means where their body will go through withdrawals if they stop using. So they've been using enough for a period of time that their body has developed that dependence. I also want to note that the younger you start consuming cannabis, so in our youth population, that number actually increases, and the more you consume, that percentage increases. So it can be as high as 20% in terms of risk for our youth, as opposed to 9%. Currently in Manitoba, of those that did report consuming cannabis, if you kind of break that down, it's about 1/3, 1/3, and 1/3. So 1/3 being that they reported using cannabis 4 times per week, about 1/3 anytime from 2 to 4 times a week, and then another third saying that they only use about once a month or less. So that's a breakdown again from the Manitoba Liquor and Gaming data. So some of the data pertaining revealed from our Addictions Foundation Manitoba research shows that those who access treatment for addictions, and it might be any type of addiction, it could be for cannabis, it could be for alcohol, it could be for opioids, for crystal meth. What you see here is that they have reported a lifetime use, and that's the highest bar, which is up higher than 80% of having used cannabis. And so, and when I say lifetime, it could be any variability. These are reports and self-reports from those who have accessed treatment. And the reason why I want to say that this is important is because one of the trends that we see is people who have alcohol use disorder or opiate use disorder often and are more likely to have reported using cannabis at some point prior to. And that kind of lens, when we look, that kind of big question, is this a gateway drug? That type of kind of thing that people think. It's hard to concretely say for sure, but certainly a lot of the literature, and when we look at some of the anecdotal, we know that there's often links. And so some of the research that was done, for example, in rats, has showed that certain parts of the brain were actually primed when they were exposed to cannabis, such that they were more likely to use other substances or experience that kind of dependence and withdrawal. So certainly that, and again, in a lot of the anecdotal, we do see that patients, for example, report having used cannabis before others. So can't say for sure direct links, but we can say, is there some type of association? Yeah. So here, this is the cannabis use in our youth, and again, what you'll notice is that percentage went from just hovering over 80 to now closer to 100 in the lifetime. Again, it goes for the past year and then several times a week in kind of that same proportion as it did for adults, but again, on a higher scale. So that, again, reflects similarly to the Canadian data. Here we see the number of individuals of cannabis as the primary presenting issue. And so that means these are persons who report that cannabis as their number one substance that they feel that they have a problem with when they're accessing treatment. And again, when you look through kind of the years from 2014 to 17, you'll see that the number, so blue for adults, hovers around the 400, and it hasn't changed a lot through the past 3-4 years. When we look at the youth, we see a little bit kind of a curve like this, and then the totals, again, higher. Now, again, I just want to put the caveat that this is self-reported, so sometimes people might have shame of reporting or might not disclose. Here, again, some more data to substantiate in terms of what is the substance that people are accessing treatment. In adults, it's actually number one is alcohol, and number two is cannabis. And I want to compare that to our youth, where 71% are cannabis, and then alcohol, 21%. So those are our social substances. Those, and when I say social, I mean that substances that are more likely to be perceived in the public as socially acceptable compared to things like crystal meth and opioids and cocaine. When we look at the adult treatment services in terms of gender, female to male, and then in past year use and daily use, again, I think the numbers are showing that kind of consistent pattern. Here we see a bit of male and female similarly, but certainly more again in the past year use, and then less in the daily use. This is interesting, and it's probably going to segue to our Winnipeg Police services, or certainly link into that. Persons in Manitoba who are accessing the impaired driving program will have reported about, again for adult, about 16% as cannabis consumers and 23% of alcohol. And with our youth, that's 18% of cannabis and 14% with alcohol. So again, when we look at how that's going to impact further for motor vehicle accidents, things like this, I think this is an important notion to think about, and also about point of care testing, which I think the Winnipeg Police Service will be speaking about. So I know this is a lot of numbers, and sometimes numbers can be a little bit threatening for some people. So I do want to say that we have a lot more information, a lot more resources that are available. And here's some of the links on our website to some of these numbers, if you want to take more time to look at it, but also more information about cannabis, the effects, and some of our programs that are targeted to that. And certainly when we move to our second portion, we'll be available to answer questions that you might have as it relates to either some of these numbers or just generally about cannabis. Thank you.
Thank you, Dr. Poulin. Next to speak will be the CEO of the Manitoba Schizophrenia Society and Schizophrenia Society of Canada. Please welcome Chris Summerville. Chris.
Canada, cannabis, candid, rather. Can I? Should I? Well, there are the warnings that Health Canada itself has on its own website, and that's one of the reasons why we're having this healthy discussion. Now, the key to understanding this whole discussion, and for some people debate about this, is understanding the development of the brain. Your brain, and even my brain, is developing from conception until age 25, even though it's kind of stopped since I'm 66 now. So, during that time period of the first 25 years, did you know that you all have your own cannabis system? Raise your hand if you knew that. See, most of you didn't know that. I don't mean dealing and selling and whatever. I'm talking about that in the prefrontal lobe cortex of every human being, you have your endocannabinoid system in which you have receptors and neurotransmitters, and that area of your brain actually involves your personality, decision-making, social behavior. If you've ever wondered why teenagers might act a little awkward, it's the prefrontal cortex. Or maybe you're parenting. No. All right. So when you use THC, it fundamentally, and especially at a 30% potency rate, it interferes with your own cannabis system, okay? In terms of impaired working memory, visual scanning, learning and cognitive flexibility. A person can experience loss of coordination, audio or visual distortion, lack of time perception. Besides feelings of euphoria, a person may experience insecurity, joy, or paranoia. So that's the aspect of the relationship between the developing brain and mental illness and or mental health problems. It's that the endocannabinoid system of your brain potentially can be overwhelmed in its normal brain developmental process. Now, I'll just move on. Is there a link? People used to talk about, and they still do, about correlation and causality. I'd rather not use those words. Here's what we know after 30 years of research, and especially the last decade. There is a clear link between cannabis and psychosis. It's one of the factors associated with the developing of a psychotic disorder. So the jury is no longer out. The risk with use varies from an estimated, 4 times to 12 times, depending on factors such as family history of mental illness, age at which cannabis use starts, and the THC potency of the cannabis. So regular cannabis use in adolescence is linked with the development of a chronic lifelong psychotic disorder in at-risk individuals. It is associated with earlier age onset, and can complicate recovery and, as Marion will discuss, one's own mental health. So who is at risk? Possibly you, possibly me. We have no way to exactly identify who will have a mental health crisis. But here's what we do know. The earlier you use, the frequency you use, the potency you use, and for sure, if there's a history of mental illness, you have that 4 to 12 times greater risk as an individual. So that helps you with informed decision making. The earliest onset, for example, is associated with higher THC skunk, an average of 6 years earlier onset. Now, we know this through research studies. People tell me all the time, oh, we have no research. We have 30 years of research. And that's why we now have, as Jeanette would know, lower risk cannabis use guidelines. So guidelines for lower use. So I've mentioned what are the risk factors. I won't repeat that. I want to go on to strains. People talk a lot about different strains. Because of interbreeding, cannabis species have cross-pollinated, and studies have shown that there's no longer a difference in plant genetics between plants labeled indica versus plants labeled sativa. High THC cannabis refers to strains with greater than 15 THC. So if a person is going to use, I don't want to say recommendation, but it's preferred that it's around 8%. But obviously people will, there's a human tendency to look for a greater potency. What about a bad trip? A lot of people ask us that. A bad trip has some features of a psychotic episode. And here's all you need to know about the bad trip. If the bad trip continues, it's psychosis. Is it addictive? In the DSM, the Diagnostic Statistical Manual, it is called cannabis use disorder. It's estimated that up to 30% of people who use will develop cannabis use disorder. Side effects coming off of it are withdrawal symptoms, as Jeanette talked about, strong sense of uneasiness, sleep disturbances, irritability, lost appetite, in some cases aggressive behavior. Is there treatment for cannabis use disorder? Depends on whether you ask a psychiatrist or a psychologist. According to psychiatry, there is no treatment, but they would all agree, hopefully talk therapy would help. What about gender differences? And I'm going to need Nadine's help on this, and I'm not going to say a whole lot because I don't want to lose my left hand. Cannabis affects men and women differently because women store THC in their bodies longer. And that has something to do with things called fat cells. So anyway, Nadine, you can help me later on. Okay. It's harder for women to quit, Marion. That's why I quit before you did. No. Men generally use for recreational purposes. Women for other reasons. What if you have a mental illness? Cannabis use can impair recovery and treatment options if you have a mental illness. If you use cannabis and you have a mental illness, you are setting yourself up for more frequent relapse, more frequent hospitalizations, greater positive symptoms in users. Furthermore, cannabis may increase, notice my verbs, may increase depression, may increase anxiety, may increase suicidal ideation. And finally, the Schizophrenia Society of Canada received funding from Health Canada and Canadian Centre for Substance Use and Addiction, and with help from the Canadian Consortium. Can we move to that? Yeah, my website, please. We've rehearsed this all day, and it never goes perfect, right? So anyway, I just want you to know about this website. How many minutes do I have, Jane? 1. Okay. So you've got to go to this website because this is where you will find the CMHA 57-page document that Marion's going to go through in a few minutes. It's a wonderful document. And it's on the Schizophrenia Society of Canada website. And it's on the stick. All right, but anyway, it's cannabisandpsychosis.ca. And it's youth informed. We've tried to develop it with language that's user friendly. It has an evidence review accepted by Health Canada and the Canadian Centre for Substance Use and Addictions. There are postcards there. Keep just flipping through it. Just flip through it. Just flip through it. They just get a little tease of it. I just want you to know that one of my passions for this is that for 40 years, the schizophrenia societies across Canada have been dealing with people, working with people who have cannabis-induced psychosis. My brother developed cannabis-induced psychosis in Vietnam in 1970 when cannabis was about 1.25% in potency. I'm not into fear mongering and an alarmist type person, I don't think. But I'll tell you, when a parent comes in and says, I wish to God someone had told us about the relationship of cannabis and psychosis, or when the police officer goes to the door and says to the parents or siblings and others, I'm sorry, your son has died or is impaired as a result of an accident through use of cannabis. So life is full of risk. You can ask what risk behavior I engaged in that resulted in my wearing a hook later on. That's a joke. I was born with a hook. No, I was born with only one hand. Okay, it's hard living with just one hook. Anyway.
Thank you, Chris. Next to speak, the CEO of the Canadian Mental Health Association Manitoba Division and Winnipeg branch, also plays a significant leadership role at the national level with the National Canadian Mental Health Association. Please give a welcome to Marion Cooper.
Thank you, Ace. So I'd like to just take a moment just to talk about what is mental health. And we've talked a little bit about the impact that cannabis use can have on the developing brain, and about one particular type of mental illness or symptom related to a mental illness called psychosis. And so when we think about the impact of cannabis on our mental health, most often we're thinking about, does this cause mental illness? And Chris spoke to some of the correlation there. But I want us to take a moment to just to reflect on, what is your mental health? And just as we need to think about what is our physical health. And so mental health is also something positive, and that every person in this room has mental health, psychological, social, emotional well-being that needs to be promoted and protected. And that's the part of our mandate at the Canadian Mental Health Association, is to raise awareness about how to promote and protect your mental health, but also how to get help and how to address mental illness and mental health concerns. They're connected, but they're different. And so we won't get into the detail of that today, but we know that cannabis can impact and create vulnerability that can lead to some mental illnesses or mental health problems. And we also need to think about how we live our lives and how we take care of our health and well-being, whether that's about exercise or drinking alcohol or using cannabis or eating a range of foods that are healthy or unhealthy. They affect our health and they affect our mental health. And so that's what this is also about, trying to encourage all of us to be thinking about how we, at a societal level, are beginning to think about how do we take care of our health and mental health. The Canadian Mental Health Association did release a cannabis policy plan actually a year ago, and part of that was in regards to supporting dialogue around the important considerations that we need to be paying attention to in anticipation of the legalization of cannabis. So I'm going to speak to a few things within the policy paper just to get us thinking about this through a health lens. So it's a little bit awkward here. So we can move the next slide. This paper was released in July of 2017, so 1 year ago. And if we keep moving on, there we go. I'll just say that part of what we were advocating for a year ago and we continue to advocate for and have dialogue with government about and partners is the important focus on health and a health focus on cannabis regime, moving away from whether this is about a legalization conversation or a criminalization focus, but really on a health focus. How do we support a public health dialogue that focuses on healthy use and taking care of our mental health? So in terms of the policy paper, we start with that statement that our goal as an association doing public education and advocating for good public policy is to ensure the protection of public health is paramount to how this policy and the legislation around cannabis legalization is operationalized at the local community level. So whether that's in a workplace or in the context of schools or neighborhoods or communities or how things are going to be sold, we need to be thinking about how we promote and protect the health of citizens. We also wanted to articulate very clearly, although we know a lot more about the impact of cannabis on the developing brain, and we heard all about trends, we still don't know an awful lot about the long-term impact of such a policy. And so we advocate and promote advancing the research agenda in an effort to ensure that we really begin to understand deeply the effects cannabis has on our mental health, and subsequently how to best design prevention programs, education, and support and treatment services. So when we hear that a psychiatrist might say there is no treatment for cannabis disorder, substance use disorder, that's a bit of a concern, isn't it? You know, as we sort of launch into this. So we need to be investing in evidence-based research really to get to better access to treatment services, but also more effective treatment services. And in the absence of those, how do we begin to invest in research? That would never be okay in cancer, that we don't know, or there's no treatment. We need to get treatment and research a priority. The other thing that the Canadian Mental Health Association's priority has been around is ensuring that there are proactive policies. And we're going to talk a little bit about workplace later on, but we need to think about proactive policies, particularly for youth and heavy users. Those are the two populations that we need to be thinking through that lens of protecting and promoting mental health and understanding the implications. We can move on. Sorry, I have a lot of slides. I'm not going to go through them all. So, when I think about this evening and I think about the importance of a public health approach, these kinds of events are exactly what is required, and this room needs to be full. And this kind of event needs to happen weekly because people do want to have the information. We need to think of a whole range of ways to get good information, accurate information out to citizens and to ensure that we are giving Canadians and Manitobans the information that they need to have conversations around the family dinner table and understand how we use information to make informed choices that will promote and protect our mental health. And so again, it's not saying, you know, no to cannabis, but it's saying make informed decisions and have accurate information. We also know that we are just at the beginning of a learning journey, and we don't have the big picture really yet. We still have an awful lot of research that needs to happen. And so the materials that are produced now and outside on that table might look different in a year after this has been mobilized, you know, and operationalized. So we need to see this website that's been developed continue to evolve and be updated and integrate information that keeps it current. I think I've talked a little bit about the research agenda, and as I said, there's still so much that we don't know, and investments need to be made on research. And that needs to really get mobilized and lead us to better public awareness. So the implementation of widespread, robust public awareness campaigns, I haven't seen too much yet, and we're looking at October as a date for legalization. So there's some important work that needs to be done, and I think, again, this is a beginning. But public awareness is particularly important if we're wanting to promote and protect the mental health of our young people. We hear every single day that there are increased rates of anxiety, struggles around depression, significant substance use issues amongst our young people. So we need to be proactive. We need to be investing in prevention and health promotion approaches in the environments where our young people live and play and go to school and learn. So those are really key priorities. So CMHA sees this important issue as an opportunity to bring home all of the messages that we speak to every single day, the importance of investing in good mental health for our citizens and not just taking it for granted or attending to it when you've lost your well-being. You don't know what you've got till it's gone. And so let's not wait for things to become a problem. Let's look at investing in how to take care of that now. Mental health recognition. So just in terms of wrapping this up, we know that our policy paper is a tool to support governments in thoughtful, deliberate dialogue and decision making, but also as a tool to support communities. That cannabis is not a separate issue. It is very much integrated into behavioral health and mental health and addiction treatment, prevention, and awareness. So that's an important part of where we want to go. We also need to remember that there are issues of health equity related to this topic, and communities that are more disenfranchised, who experience more poverty, and are at greater risk for other kinds of struggles, need to be considered as we look at supporting communities to have access to good information to make the most informed decisions about health and well-being. We need to ensure that there's a real focus on health equity and ensuring populations that may have multiple things that they're attending to are considered in a particular way around this. And then I think finally, I just want to kind of quickly just highlight that a part of this discussion, although not the focus this evening, is the two things. We need to be thinking about treatment options for heavy users and youth, but the other important part of this conversation is understanding and having good access to medical use of cannabis. And we can't really have this conversation because many Canadians, many Manitobans have many questions about medical use. And so there needs to be a separate framework around medical use and access to good information, and primary care providers need to have access to that because they have patients coming and asking for help. And right now, we are still developing some of that information, and so that's an important part of being healthful in this dialogue. Thank you. Sure.
Thank you very much, Marion. Our next speaker is with the Winnipeg Police Service, the training division, and when not in uniform, does a lot of work in our community. Please give a warm welcome to Constable Jason English. Jason.
Thanks, Ace. I'd just like to start by, like the rest of us, thank you for coming tonight. I'm very happy to have been invited to this panel. I think the public forum is a great venue for the free flow of information, and nothing we do is secret. Everything's transparent and out in the open. And sometimes interpretation or an explanation in a question-based environment is a great way to sort of advance that along. And I want to just echo what Marion was saying before I sort of get into the meat. We're entering a new era. We've had alcohol present in society in a legal form. Well, we had it, then we didn't have it, and then we had it again. For a very, very long time, and there's been a lot of messaging from the government, messaging from health systems, from school systems, from peer groups, from the obviously the criminal side as well. And the education has become quite robust. We see an era now where a designated driver is just something we do in the alcohol world. And this now, with the introduction of the legal consumption, is going to open a whole other social experience for multiple age groups that haven't been down this path before. Certainly there's been illicit users for a long time, there's been medical users for a long time, so that's an educated segment of the population, but for everyone else it will be new. And when we look at the statistics, as everyone across the line has spoke to, and certainly our traffic collision statistics reflect the same, cannabis is very much that sort of 19 to 40-year-old target population. So young, decision-making, the whole rest of their life in front of them, and so that education piece is very important. I was asked to speak to whether cannabis impairs driving and what we're going to do to detect that. Cannabis is a psychoactive drug, where that's sort of out in the public space. And it's any drug with an impairing potential causes you to enter into the impaired driving scenario. The one difference that cannabis appears to present with versus alcohol, and again, just talking, we're not talking about all the illicit drugs at this point. We're focusing on cannabis. The perception seems to be that cannabis is less impairing. And part of that perception is because it's a psychoactive drug for impairment, it acts on things like space and time appreciation and distortion and balance. It doesn't physically affect your limbs like a central nervous system depressant like alcohol would. So when you exceed certain limits in alcohol, you functionally become, there's a deficit. Whereas cannabis, a lot of it is largely cognitive, and so the perception skews along with that cognitive, and the feeling of being less impaired is present. Like any drug, you can consume it and not be impaired. Depends on the level that you've consumed. Cannabis is not as predictable as alcohol. Just the THC factor alone, depending on if you consume something down in the single digits or in the high double digits, that alone, let alone your physiology, that if there's anything else on board, if you combine alcohol with cannabis, if you have any pharmaceuticals that you're taking as a result of a prescription, all of those have influencing factors on it. Social messaging and education is the most important perspective here, and this is overwhelmingly the large message that we want to convey as the police. We're not judging consumption of cannabis. I'm judging your collision decision. And making the decision to drive a vehicle while you're impaired by any drug is a poor decision. And sadly, there's a lot of second and third order effects that are attached to that with respect to the families that are impacted. As Chris said, I've been that guy coming to the door and making those notifications. With respect of the physiological effects of cannabis, some of the things that we look for are the red and bloodshot eyes. One of the medical rationales for the use of cannabis is glaucoma. It's used often for that. And one of the glaucoma benefits is that it causes that vasodilation and takes the pressure off, which allows the blood vessels in the eye to present as very obvious and gives that bloodshot eyes. It also causes what's called a lack of convergence. So if you've ever, when you were a kid, you've tried to follow your finger and cross your eyes, or you made your friends do it, the ability to cross your eyes is lost with consumption of cannabis. It dilates the pupils. It's not a hard and fast. It's not everybody all the time, but overwhelmingly the majority of a cannabis use will see a dilation of the pupils. It causes something called a rebound dilation as well. One of the tests that we do in our drug recognition programs is a series of evaluation of the pupils, and one of them is under direct light. And when you shine a light in the eye, everyone's aware that your pupil constricts. And with cannabis, because it wants to dilate, it fights the light, and it keeps growing back into a dilated state. The pulse is up, the blood pressure's up. We have attention span issues, relaxation, euphoria, depth perception, memory issues. drowsy presentations. So these are all things that one can see from an observable sign perspective, as well as then the driving task. So the issue, a large overwhelming issue with the driving task of cannabis is the divided attention. And as you're well aware, if anybody with a driver's license, divided attention is exactly what we're doing. We're regulating the gas pedal, we're controlling the steering mechanism, we're scanning for lights and street signs and pedestrians, paying attention to the speed changes, listening to our passenger, listening to the radio. There's a lot of things going on, and so when our ability to divide those attention tasks is impaired, that creates the problem. And so what we see on the road, like the initial indicators without, not a check stop environment where you roll through an MPI-sponsored check stop and we just talk to you. If we're driving, we see, or the cause of complaints from society, we see speed changes, too fast or too slow, or both. We see perception and time changes, so the light will turn green and the vehicle won't move. The light will be red and we'll get double or triple stops. Coming up to the red, we'll stop short and then we'll finally realize that we're not quite there. And we'll make that distance change again. So those are some of the things that are observable from a law enforcement perspective to certainly create that initial indication of a potential for impairment. As far as the detecting, we'll go quickly over. We've been doing drug-impaired driving enforcement for a long, long time. This is not new. It's been in the criminal code since about 2008. We have currently standardized field sobriety testing that's done, as well as drug recognition expert evaluations that are completed. Those still stand. Those have been the gold standard for a long time. The SFST, the standard field sobriety test, is a roadside interdiction where the reasonable suspicion of consumption causes the SFST to occur. If that SFST is performed poorly, an arrest is made and a demand is then made for a drug recognition evaluation. That's the present state right now. What the new bill introduces is a roadside screening device for the consumption of 3 drugs. So if you've been through an MPI check stop before and you've blown into the ASD or you've seen an officer with it, that's an alcohol screening device. The oral fluid device is the same, essentially, principle for roadside drug detection. It'll be a saliva-based sample, and that, again, a positive finding for that will result in an arrest. And then what is new is a demand for blood can be made at that point, or a drug recognition evaluation as well. So those are sort of the new roadside and post-arrest things that are available to law enforcement. And then with that comes the 3 new offenses. So at or over 2 nanograms per milliliter, up to 5 is the summary conviction offense. And then there's 2 hybrid offenses. One is over 5 nanograms per milliliter of just straight cannabis is a hybrid offense, as well as if there's alcohol in excess of 50 milligrams percent, the cannabis threshold drops to 2.5 nanograms per milliliter. So if you're consuming cannabis and alcohol combined, they create an offense unto themselves. I think that's, we're good. Yep, thank you.
Thank you, Constable. Appreciate you being here. Appreciate her being back in this town. She is back and is the new executive director of the Women's Health Clinic. Very happy to have her home. Please give a warm welcome to Nadine Sukermani.
Thank you. Can you hear me? Is that okay? I hope so. I don't have the loud, booming voice of Chris, so I'll do my best. I'm also losing my voice, so I apologize. Thank you, ACE. Thank you, Chris, for having Women's Health Clinic here. We're really pleased to be here to provide a gendered lens to this discussion. We believe society benefits most when drug policy is designed to help people living with addiction live better lives rather than punish them. And I believe this is what the Canadian government is embracing in principle with the upcoming legalization of cannabis use. For those who aren't familiar, Women's Health Clinic is a feminist nonprofit community health clinic. We serve all genders and we're located in downtown Winnipeg. Our values of choice, inclusion, social justice, innovation, and integrity guide our programs and services. We believe people are the experts of their own lives and they deserve the fundamental respect and support in the choices that they make in terms of their own health and well-being. We also recognize that the concept of choice is complex. The options available to any individual exist within a larger context, and this would include issues like poverty, racism, colonization, violence, etc. We also understand that health is influenced by social factors above and beyond physical health, but not limited to age, race, class, geography, ability, sexual orientation, and gender. At Women's Health Clinic, we also recognize that people's lives are layered and complex, and that the unique life experiences and circumstances available to people who access healthcare are diverse. We recognize and support the need for a clean, affordable cannabis supply and the ability for people to control their supply by growing their own. We recognize and support the need for good, balanced public education, school education, and a model that's based in a harm reduction principle, which I'll talk about a little bit further on. We oppose the stigmatization of people who use cannabis, which has already been mentioned, and we work with people to receive positive health outcomes wherever they are. Stigmatization and discrimination of people who use cannabis jeopardize their safety and access, and it creates an environment where people won't speak openly about what they are engaging in, the choices that they're making. When folks don't disclose this to their healthcare provider, it puts them at more risk. So we strive to create an environment where people feel comfortable disclosing and therefore accessing education, increasing dialogue, making a plan for themselves and their healthcare, regardless of where they are at. Just a few quick facts as it relates to gender and some of the topics that I'll talk about. For example, pregnancy. Substance use during pregnancy is common. It's common by women from all social and economic groups. This crosses class, it crosses race, and it crosses all communities. So again, back to that piece around stigmatization, I think we do have an idea about who uses cannabis, and I think it's something we would like folks to really think about. Why? Why do we take those messages in, and why do we continue to perpetuate them? Many women have supports in place and are able to stop using if they choose, when they learn they are pregnant. Other women continue to face addiction and health challenges, and our role is to support them in whatever choices they make. What we know as well is that alcohol and tobacco are the most commonly used drugs during pregnancy. And as you know, there's a ton of health education out there that speaks to all members of society about this. Cannabis is the most commonly used illicit drug. Now, we use that term now, but as we know in October, that context will change. Tobacco and alcohol are also currently, based on the research that we know, the most harmful drugs for fetal health during pregnancy, and in the long term for those prenatally exposed. That being said, and if we were to push that out, what we also know is infants who show withdrawal effects from substances like heroin and other forms of drugs, we do know, and research has shown that they do not necessarily have any effects later on as adults. So again, if we look at the research that's there around alcohol and tobacco, and then additionally the research that's there around the other end of the spectrum, we know the long-term effects based on the research that we currently have, and as some of the panelists have said, That research will change over the next couple of years, but what we do know currently is there is no long-term effect on individuals. What we also know, and at the clinic we strongly acknowledge, is that health outcomes are more closely related to factors like homelessness, poverty, poor nutrition, stress, and infections rather than drug use itself. So these are the bigger outcomes, the social outcomes that we focus on in our work. There's no one approach that works for all women, and best practices must always reflect their context. For this reason, we opt for a principle-based approach, and this is modeled after feminist models across the country, across the world, in fact, and it takes on 4 particular aspects. It is women-centered, it's trauma-informed, equity-informed, and it is harm-reducing. So I'll just speak to each of those briefly. We talk about a women-centered approach at Women's Health Clinic because that is our primary population. It recognizes sex and gender-related influences on cannabis use and offers support for a woman's choice when it comes to her body. In the perinatal period, a women-centered approach prioritizes her health before, during, and after pregnancy. And a women-centered approach also builds her autonomy and supports her health and social priorities, which also supports her ability to support her family. If we only focus on the risks to fetal health during pregnancy and the potential harm to fetus, this causes an incredible amount of undue guilt and shame, which can diminish a woman's sense of herself, her self-esteem, her confidence, and it actually also contributes to the notion of a good mother. And when I say that, good mother, I mean in quotations. When harmful judgments are placed towards a mother or to a woman who uses cannabis while pregnant or while caring for her children, these attitudes can erode her sense of self, her self-confidence, and can cause her to hide her use from those who can support her. So again, we support ensuring that a woman doesn't feel that attitude or that stigmatizing judgment during her interactions with us. These attitudes also disproportionately affect newcomer women, Black communities, Indigenous communities, communities of color, and poor communities. So again, we really want to be aware of where these biases and judgments come from. Recently, I was here in Winnipeg. I've recently returned, as Ace mentioned, and I come from Toronto, but I was born and raised here in Winnipeg. So as I come back to the city, I'm becoming more connected with friends and people who I've known for many, many years, but have had some distance between us. A couple of weeks ago, I was at a barbecue here in Winnipeg in the River Heights neighborhood, which is a much nicer neighborhood than I grew up in when I was here. And I won't mention that neighborhood just to ensure no one feels a way about that. But when I was at this particular barbecue, I was, interestingly surprised at when one of the members of the host of the home that we were visiting pulled out some cannabis, I'll use that word, and started rolling a few joints and passing them around. I was kind of looking around. Folks were lighting up and enjoying their after work. It was a weekday. Most of the people in the circle were professionals. I would see lawyers, accountants. Everyone kind of, ended their very long day and felt like they needed to relax. I did not. I don't partake, which is not, again, to say anything about the group of people that I was hanging out with. But that being said, there were some children there. It was a barbecue. Folks were smoking. There were children there. And I kind of looked around the group and I thought, if we had placed a different lens over the group, in other words, what I will share with you was this group were upper to middle class white folks. I'll just say that. I was the only person in the group who was not. And I kind of looked around. I had this moment of, if this were a different group of people in the north end of the city with a different lens placed over the group, this would look quite different. Child and Family Services, police perhaps, other folks, neighbors might be peering over wondering, there's a pretty strong smell of cannabis floating over that fence. And I felt like it would have been quite different. So when I talk about how race, how poverty, how socioeconomic issues come into play, I think of that picture, and I think about how that picture would shift and flip if it were in a different part of the city at a different time. So that's really to the heart of that piece for me. The second one I shared was trauma-informed, and it really does recognize how common trauma and violence are in the lives of women and girls, and identifies the need for physical and emotional safety. Services that support safety, empowerment, and strengths for all clients can happen without the need for disclosure. So sometimes people say, well, when you talk about trauma-informed, you're re-traumatizing people because they have to share their story. Well, in fact, if you work from a perspective, as we do, that violence touches the lives of most of the women that come through our doors, and we provide that service through that lens, then folks don't have to disclose, but they can leave us feeling safe, feeling like their emotional and safety and sense of well-being are being held. And again, we also acknowledge the ways that intergenerational trauma can come into play here. The third piece that I mentioned was equity informed, and this again just goes right back to the socioeconomic and other factors that come into play with regards to the women that come through our doors. But the last one that I want to touch on as my time is rolling up is harm reducing. It is our position that cannabis use can be included in a harm reduction approach towards healthcare while ensuring that our clients have information they need to make informed choices for the best possible health outcomes. The Canadian Harm Reduction Network defines it as policies, programs, and practices that aim to reduce the negative health, social, and economic consequences that may ensue from the use of legal and illegal drugs without necessarily reducing drug use. When it comes to services for pregnant women and mothers, it's an approach that helps to reduce the negative effects of alcohol and drug use at the same time as helping women meet their immediate health, social, and safety needs. The BC Centre for Excellence for Women's Health describes working with women during pregnancy as an opportunity to support them in improving their health, including efforts to decrease or stop if they choose, and that way also create environments where they can use in a more safe way. They also recognize that substance use is just one factor among many that shape a healthy pregnancy, and reducing or stopping at any time can have positive effects on their health and their baby's health. A few strategies, if I could just end with these: education and outreach, which has already been shared, low barrier access to services, collaboration or more collaboration between healthcare and other social services, access to safe, non-judgmental addiction counseling, assistance with the day-to-day needs like transportation, childcare, and food, and access to integrated program models. So I had a little bit more, but my time has run out. I want to thank you very much for listening.
Thank you, Nadine. Next up, Dr. Sitar is a professor with the Department of Pharmacology and Therapeutics at the University of Manitoba, and here representing the Alzheimer's Society of Manitoba. Please welcome Dr. Daniel Sitar.
I'd like to thank the organizers for asking me to be here tonight and to try and leave you with some wisdom, I hope. So I was asked to address issues related to the elderly, and I've spent a good part of my career looking at that issue to try and improve treatment of chronic diseases. So if you're lucky enough to get old, and I think I'm the oldest one here, I'm 74, that you're likely to accumulate chronic diseases just because you've lived that long. So what we've been conditioned to believe is that if you have a disease, there's a drug that's going to fix it. And that's somewhat true. I think what you do is you modify the pathology, if you're lucky, so that you maintain a better quality of life than you may have had if you didn't have access to the drug. That is not invariably true, and it's allowed me to have a career for a long time trying to put it in perspective. So if you're old and you have a lot of disease, the likelihood is that you're going to be taking a lot of drugs. And the side effects increase with the number of drugs taken, and others and our group have demonstrated the increased risk with the number of medications you take. Next slide, please. This is a little wiped out for this audience, but what I wanted to do was emphasize a couple of points that the most at-risk people for drug effects are the very young and the very old. And I'm only going to talk about the very old today. I don't think I'm very old, but they put me in that group. There is a genetic impact that no one's talked about here. And just because you have cannabinoid receptors don't mean that they're the same as my cannabinoid receptors. And some people have multiple copies. Some people have deficient cannabinoid receptors. So it's not unusual that different people would respond differently to the same drug. And that's another reason why I've had a career in health sciences. So if we take multiple drugs, they're going to interact with these receptors. And depending on the mixture and how many of them there are, you're going to get a different response. And so what you look at is something called the benefit to risk ratio. There is no substance on earth that has totally beneficial without risk. That includes water. Okay? So we need to learn how to modify the drug doses to optimize the therapeutic benefit and minimize the effects that we don't wish to see when we are persons who are ingesting these substances. Next slide, please. I just wanted to show you that in spite of what you may hear, cannabis does have medical uses. We are learning how to use it well. And last week, the FDA in the US actually licensed cannabidiol for intractable epilepsy in children. This is not going to make a lot of money. You have to watch the marketing because they'll say, well, my child has epilepsy. I want them to have this drug. This drug is to be reserved for people with intractable disease because multiple seizures per day cause brain damage, and the benefit to risk in those children are without doubt, but it only helps half of them. So it's not a magic cure. And this is not the memory impairing THC that you hear about. This is a supposedly mind-altering form of cannabidiol, although literature suggests there is interaction between this chemistry and the tetrahydrocannabinol, and we really don't know enough about that to make much more informed comment. Next slide, please. I put this slide up because it reflects how society perceives and markets any drug that comes into being, and THC or cannabinoids will be drugs that will be legal in Canada in October. So initially there's great enthusiasm. So the enthusiasm is the curve going up. It's done in a limited number of people, so everybody thinks it's God's gift to therapy. As it's used in more people, all of a sudden side effects are demonstrated that people didn't expect, and the frequency changes, and so the use goes way down. So people who are thinking that this substance may be useful then develop a process for choosing who should get it and how much they should get, and therefore the enthusiasm goes up again. As the drug gets used again, the chronic side effects then start to appear that we didn't appreciate because all of the tests were with acute drug use. And so the use then goes down, and it keeps oscillating till the end on the right, where the drug finally reaches the hopefully appropriate place in our society and its therapeutic use. Next slide, please. These 7 reasons are why old people essentially have more trouble with drugs. Your heart doesn't work the same when you get older, therefore your tissue perfusion changes. Your liver shrinks as you get older, so it's not as big as it was when you were younger. Your body water, as a function of total body weight, decreases. Because you have a smaller liver, your liver function is not going to have the same capacity as a younger person. If you have altered mental function, and what we call that is minimal mental dysfunction, and we could say that early Alzheimer's disease represents one of those types of conditions. that the use of cannabis is going to increase that impairment, because any drug that affects the brain affects a brain that is aging and works differently from the brain of a younger person. And the progression of the diseases that you have as you're trying to maintain your quality of life will result in you probably using more drugs or different doses of drugs. Next slide, please. So here are the issues with older people using recreational cannabis that would concern me as a healthcare individual. If you have lung disease of any kind, chronic obstructive lung disease, asthma, difficulty in breathing, wheezing, inhaling the smoke is going to make it worse. And so one say, well, we could try edible cannabis, but that's not going to be legal in October. It's going to take a year for those products to come. The pharmacology of oral cannabinoids is different than inhaled cannabinoids, both in onset and duration of action. We really don't know the outcome of that yet. That's an experiment that is going to happen in the next few years. If you have heart disease, any smoke that you take in reduces the oxygen delivery by the blood. It increases the hypoxia in your circulation. It increases chest pain due to angina. And so smoking marijuana is not going to be a good thing for people with underlying heart disease. And you heard from the law enforcement representative on this panel that heart rate goes up and blood pressure goes up. And if you already have a defective heart, both of those things are not good, because your heart rate in an older, unconditioned person is already faster than a heart rate in a well-conditioned individual. Actually, if you're older and you're in shape, your heart rate is slower when you're older than when you're younger. And we usually don't talk about that. If you have mild cognitive impairment, all drugs that affect the brain will at least be additive when you use them together. So if you are old and you're on a medication affecting your brain for whatever reason you're going to take it, and you add alcohol or cannabis or any other drug, you're going to increase the deficit, and therefore your ability to function appropriately in your home environment is going to be decreased, and it may in fact precipitate institutionalization because you're no longer capable of managing your own affairs. So drug interactions relate primarily to the ability of the liver not to handle the drug as well as it was when you were younger. If you're taking multiple drugs, they fight for the same disposition mechanisms, and therefore the rate of elimination changes and has an effect in and of itself. And some of the drugs that you need to be concerned about are warfarin as an anticoagulant, which some of you may be on in the audience, and some of the anti-diabetic drugs. And so there are interactions. So how do you know? I mean, in 10 minutes, I can't give you the whole answer. Next slide, please. But I can give you places to look and think. If you go to this website by the American Geriatrics Association, there is a list of drugs of concern for the elderly, some of which will interact with cannabinoids. Next slide, please. Okay, the best source of information I found, and it may be difficult for some of you to read because it's in fairly involved language, but last year the American Academy of Sciences published a review of all the information on cannabinoids in the literature and its veracity, whether it in fact it was believable, where the deficits were, what it was we should take away, where we need to do more work. And I strongly refer you to that document. That top document, if you download it on your computer as a PDF, it's free. Otherwise, they want to sell you a book that will cost you money. So yeah, get your children or your relatives to download the PDF for you for free, and you can take a look at it at your leisure. And then again, there's a website down below for the drugs at risk for old people. Again, the American Geriatric Society. It is a very highly regarded website with respect to drugs in the elderly.
Wendy Hofford, please welcome Wendy.
Thank you. All right. Well, we're going to start by polling the audience here, because I'm here to talk about policies in the workplace. So please raise your hand if you're an employee. Okay, look around. You're not alone. Do we have any business owners here? Yay! Kudos to the business owners. Awesome. All right. So as we look at this, it's quite interesting because as much as we know that this is happening, this change is coming, legalization, it's like no surprise. It's been in your workplace already. You just didn't really think about it much. So what is really good about this, and there is a good point about this, is the fact that it's really getting us to look at our drug and alcohol policy. Now, I spent a lot of time in the construction industry. I'm a National Construction Safety Officer as well. So safety is your number one as an employer, and we have some employers here. And employees, it's your obligation to make sure you're safe and to keep others safe around you. So understanding that when we're looking at cannabis in the workplace, we're also looking at any other drug or alcohol or anything that can cause impairment. Jason was talking about impairment earlier. And as employers and as people that are working in a workplace, it's very important that we show up and we're not impaired. And so that's really where I want us to go. I want us to be not putting down this legalization, but to look at it and say, okay, how are we going to be proactive? How are we going to educate our people? And how are we as business owners and employees, what part do we own? And that's really what I'm here to talk about. So in sake of time, because I know Jane's got our little numbers there to tell us how much, I'm going to try and keep this short and sweet, but I really want to get to the point of some of the policies we want to look at. There's two things, and I said it before. Number one is that in the workplace, we have a duty to make sure that our employees are safe and go home at the end of the day. And I think we'd all agree that that is absolutely what we want. And I think if Jason and the rest of the people up here would also agree that we want everybody on the roads driving, everybody safe. So we start with that. The second thing, though, as employers, we do have a duty to accommodate up to undue hardship. Now, there's going to be times, and some of you may have experienced it already, whether it's cannabis or anything else, but if there's a dependency or disability and somebody is using recreational cannabis to ease their pain, and you know that they have a disability, you have a duty to accommodate whether you like it or not. So you can see that there is going to be a bigger can of worms here, and there's a lot to look at. So one of the major things that you want to look at for sure is going to be a drug and alcohol policy. If you haven't looked at it in a long time, how many employees know and read their drug and alcohol policy for their company? Wow, I would have thought, yay, kudos if you've done that, yes. I'm not going to ask you what it means, though. I won't hold you to that test. If you haven't looked at it, you might want to ask if your company has one. And if you are a business owner, you better have one. And if you don't, it's time to either blow the dust off the one you have, or it's time to make one. So when this started coming, I found out about legalization. I actually pulled out ours, blew the dust off our policy, and I was missing some key points. Working with our lawyers, reaching out to human rights, all the things that you do in your HR, and did a lot of homework on this. And there's two things you want to make sure you have in your policy. Number one is you want to be able to define what impairment is, and you also want your employees to know that they are expected to be fit for work. And that's the clause I use, is fit for work. So when we look at impairment, what is impairment, right? So impairment is the inability, I apologize, if somebody has impaired, the inability to function in a normal capacity. So when somebody comes to work and they're not acting normal or they're kind of off, and you notice that, and if you're a supervisor and you know that this person's off, you're actually obligated to take them aside and find out what's going on. So you want to make sure you have that conversation. Now, fit for work, what does that mean? Fit for work is the ability to perform your job safely and productively in line with your job tasks and what's expected by the company and your managers. These are the things you need to outline in your policies. So that's the drug and alcohol policy. There's another one. If you have company vehicles, then you make sure that you want to put a clause in there that no one is to operate any of the company vehicles unless they are fit for work, right? And they are not allowed if they are intoxicated or, what was the other word I was saying here? Or impaired, sorry. So these are the things you want to look at. So if you know that there's somebody that has been using and they're coming to work, then as an employer or a manager or supervisor, you want to be able to take them aside and have a conversation with them, not in judgment, but to assess whether or not they are impaired. And if they are, then you have to determine, depending on your company policies, what your procedures are, what are you going to do with them? You're certainly going to put them in a car and send them home. That would be silly. So you really want to think about what that process should be, and what is educate your people, educate your frontline managers. If you've got a duty to accommodate, maybe they are on medical cannabis and they're smoking it. Well, that's going to impact your smoking policy. It's going to affect your scent sensitivity or your scent-free policy, if that's what you have. It opens up a whole big can of worms, so you want to make very sure that that's what you're considering. If your company is safety sensitive, such as construction, or maybe oil sands or anything like that, those are, transit buses is another good one. Those safety sensitive jobs are jobs where it could cause damage to, or harm, I should say, to the public, to yourself, and to others. So in those cases, drug testing might be an option. I warn against it for anybody else that's not in that, and if you do decide that your company, maybe drug testing is something you want to consider, then I highly suggest aligning yourself with some good lawyers and get to know the Human Rights Code very well, because it's a very slippery slope. So if that's something you want to look at, that is something that is still pretty dicey, even on the testing. I know Jason maybe touched on a little bit, but the fact is, even if you did test right now, and THC level does show up, it doesn't mean that they're impaired at that time. And that's the only reason you would be testing, is the measure of impairment. So again, this is a minefield that we're walking into. Educate yourself as employees, educate and understand what you need to do. If at any time you're having a conversation with your employees, you make sure you document it. Everything needs to be documented. If you're doing an orientation, make sure that the orientation, when a new employee is coming in, that they're reading and they're very full aware of what your expectations are and what your drug and alcohol policy says, and what would happen if they do come to work and they are impaired, what's going to happen. You need to make sure that they're very much aware of that. I think that's enough talking for now. All right, thank you very much.
Thank you very much, Wendy, and to everyone on our panel. Please give them a big round of applause. Thank you very much. Okay, so what do we have for time? Okay, so we will we'll take a quick little break. If you want to drop your questions off in the basket, by all means. And then we will meet back. So the first question will be at 8:40. At 8:40, we will begin the Q&A, and it'll start right at 8:40. So we'll meet back here in a few. So if your question is directed to someone specifically, that is cool. If I'm reading it from one of the cards, whoever feels most comfortable answering, take the lead. And I don't think we're going to get through them all, to be perfectly honest with you, because we got lots, which is awesome. We'll start. This is John, and John will do the first one. We'll alternate between live questions and from the cards. So, John.
I got the distinct impression that cannabis affects short-term memory and or its derivatives. And does it also affect maturation? In other words, teenagers become mature at a slower rate if they've been taking cannabis as young people. And can cannabis be used as a substitute for morphine in people that are terminal? And has cannabis been used, I thought I heard this, but I didn't quite know, has it been used to help alcoholics get off the alcohol? Thank you.
Okay, stay there, John, just so, the first one, just so we're clear.
Okay, is it well established that cannabis affects short-term memory?
Okay.
Yes.
Who would like that?
Yes, it does. Okay, that's the direct answer. We don't know what the long-term consequences are because the drug was not legal. And so a lot of the information we have is self-given. And we know when we do studies where we actually do a test to see if people are telling the truth, that the responses are sometimes not the same. But I believe the evidence is probably strong enough that the prohibition for people under 19 using it is probably reasonable. I don't want to be quoted on that, but from what I've read and what I understand about brain development, that is probably a reasonable guidance about who should and shouldn't use it. And you're old enough to know, as I was, that in spite of the law, alcohol and cigarettes were available to us at a very early age before we ever got legal. So in spite of what's written down in the law, we know that these substances will get to our young people, and the consequences of that we will learn in the next generation.
Is what you said also applicable to the derivatives of cannabis?
We don't know because cannabidiol is very different from THC in its effect on the brain. Cannabidiol is actually very interesting in intractable epilepsy in children. But that doesn't mean that every epileptic should get cannabidiol, that it has a specific population, and even in that population, it only works half the time. You know, in another 10 years, I may be able to give you a better answer, but at least we've broken the barrier that is now available to the kids with the worst cases of epilepsy, where the repeated seizures has tremendous impairment on brain development. So just hopefully reduction of the number of seizures will allow them to have a more normal life than they would have had otherwise. That's the best answer I can give you. The other one with morphine is THC actually only works in half the people. Its value is that it doesn't cause the same respiratory depression as morphine. And what it may allow you to do is lower the dose of morphine that you use with the THC for pain management. And in fact, the largest population I know now that is using THC as a co-analgesic are older people with arthritis. It's helped them to remain much more functional than they have been. Where that's going, I can't tell you for sure, but I did check with my colleagues and that use is growing.
I can add to that certainly for pain management. It's really important to understand that pain is complex. There's different kind of pathways through that, what we call neuropathic, so nerve type pain, organic type pain. The morphine, like other opiates, work on some of the mu receptor deltas, the kappas. Obviously with the THC, it's working on the endocannabinoid. So we know that there's sometimes synergistic effects. And when we look at pain management, we want to address some of these different ways. Also the emotional component. So looking at lower dose of multiple medications, and certainly there's some research that's starting to look at when people are using THC or cannabis, it's possible that they require less of the opioids. So if you're talking specifically about that. But again, amongst opioids, just like cannabis, we metabolize different, we have different receptors. So there's a lot to consider, and there's not just one simple answer.
Is there any evidence that it's been used with alcoholics to help them get off the alcohol?
No, we don't have, from my knowledge, any evidence that there's cannabis that reduces the alcohol consumption. Opiates is different.
Thank you very much.
Thanks, John. I'll read this next one. If anyone wants to saunter over to the mic, then we can go to you next. So this is interesting. I'm assuming we'll go to the constable for this, but so this person is currently in a safety-sensitive position and uses an employer-provided vehicle on a daily basis. They are also a medical cannabis user, does not take the prescription while at work. However, with the saliva blood test for impairment changes, how can this person ensure that they are not impaired according to the test? They do not feel physically impaired. And then a huge question, can you access the test so you can personally determine that you are not legally impaired?
So I'll answer my piece. I think probably more so for Wendy in the safety-sensitive work. Emergency services is going through the same thing. We're going to be subject to the same scrutiny. Impaired is just that. So we've had a couple of descriptions of impaired. The ability to operate a vehicle safely is impaired. And that is the subject test. As we've talked about, Jeanette just actually mentioned about some overlapping effects and the reduction of dosages based on secondary consumptions. The same holds true with cannabis. So if there's other pharmacology involved, there may be sometimes the accidental impairment, as we see in the geriatric population. That's certainly one avenue. The other is this tolerance, and it's more understood, I think, with alcohol and narcotics. But as the body is getting used to consuming, there is a tolerance factor there. So one may consume and not actually be impaired, whereas someone who's never consumed could have the same amount and be impaired. That is the difference with impaired by roadside. Something's caused that the attention has been drawn to something that's incorrect. So whether it's driving behavior, we have that reasonable suspicion of consumption, that's when law enforcement gets involved. From a business perspective, or on operating a motor vehicle at work with those internal regulations, I'm hoping that a dispatcher of that vehicle would recognize someone who showed up to take the keys if they were actually impaired. The per se limits would come in, and that's, I think, if I understand the question right, the roadside screening device even will just say positive or negative. It's not till we go on to blood that we get an actual nanogram level. So it's not like those little giveaways that they have for marketing where you can blow into the little straw and it'll give you a ballpark figure for alcohol. We just don't have that. It's present or not. The devices are extremely expensive. It's about $40 a test, and it's just for a positive or negative, not a nanograms percent. So workplace, I would refer to.
And I can add to that too, Ace. Now, can you just repeat it again? Because I think it was that they're on medical cannabis, please?
Correct. They a medical cannabis user
Yes, okay.
and does not take the prescription while at work.
So what is nice about that, number one, is because this person has medical cannabis, which means it's been a prescription's been provided through a doctor. So the employer doesn't have the right to know why, but does have a right to know what the side effects of any drug is. So my advice to anybody that's on medical cannabis, or if you have an employee that is on that, you have the right to ask for, and actually I use a form letter, so if anybody wants to reach out to me, just do so, either a pharmacist or their doctor, on what the level of THC level is, what the side effects are, and if there's any other medications they could be taking rather than the medical cannabis. And if there's a certain amount of time that they should not be operating a vehicle, that doctor should be able to tell us so that we can make the accommodation properly around that, whether that means that we have to remove them from a certain job of maybe handling that vehicle at that time until after. So there's a lot of things you can build accommodation around, but you need to know that information so you know what it is you're dealing with. And in fact, any drug, medication that a person's on that could cause impairment of any sort, the employer or HR department should really know what the side effects are so that they can help you to be successful and be able to help accommodate you while you're going through your treatment program. But one thing is to know for sure is if you're on medical cannabis and that expires, it now is considered recreational, and now it's a little different story. So you want to work very closely with your employer so then we can make sure that that accommodation stays and that you can do your work and do it properly, and you're not going to be impaired because we know what you're dealing with. Hope that answers the question.
Thank you. Let's go to the live mic.
Hey there. My first question is to Nadine there with the mothers, the female place. I was just curious because I've heard about the cannabis and pregnant Jamaican mothers study, and I was just curious if you'd heard about that and what your take is on that.
No, I haven't. What does it say?
Well, I don't have it in front of me, but as far as I'm concerned, it showed that cannabis use in the Jamaican mothers actually resulted in better infants, like better responsiveness, better autonomy, a lot of things, which makes sense considering that cannabis actually mimics endogenous neurotransmitters in mother's breast milk, which is part of why it being illegal for so long is actually it's criminal, actually, what it was. It was unconstitutional, and I'm glad to see it being repealed. But yeah, the Jamaican Mothers study I found was the best indication that it actually should be used. Not necessarily that it should be used, because that's up to the individual and their doctors and understanding, but that it probably could be incorporated as a much better drug than tobacco or alcohol for pregnancy.
Certainly, and I mean, it supports what we're talking about in terms of harm reduction, and it destigmatizes the use. So I'm not familiar with it, but thank you for bringing it up, and we will certainly, as a women's clinic, and as we develop further our position statement, we'll look at it. Thank you. Thank you for sharing.
Jamaican Mothers study, pretty easy to look up. Thanks. The second question I had was...
Let me just comment on it as a principle in the research that our society has considered, is that in the use of cannabis, it's important to make sure there's a balance of THC and CBD. So if there's not that balance, then there's the potential for more harm.
Yes. My next question actually was directed to Captain Hook.
Okay, great.
Yeah. He laughed. Okay.
Yes?
Yes.
I'm
He's got a
Captain
good
Hook.
sense of humor. I'm just curious if there is any research on the percentage of the population with schizophrenia or psychosis issues, like say from the 1940s before the use of cannabis sharply spiked upwards, and how that relates to cannabis use.
Okay. I thought I would remember the answer to that. Marion, see if you can help me on that. The question is the studies prior to and as of today,
Yeah, the
and
percentage.
the spike.
The percentage.
It has to do, again, with the balance of THC and CBD.
Right.
So
THC is
therefore, when there was that imbalance, there was a higher correlation to psychosis inducement. All right, so prior to, okay, I got it now. So prior to, when there was a greater, during my brother's time in the 40s, there was more of an equal balance of THC and CBD. So
But
there were
users
lower,
were quite
so there
lower.
were, research said there was no correlation or causation to psychosis. The research today is showing more of a correlation, or whatever you want to call it, because the potency is higher. The THC is higher, and
Does that
there's less
include extracts?
CBD.
I mean, hashish has been around for thousands of years, but yeah, I guess that sort of answered my question. I'm really excited to look up cannabis and psychosis.ca. Leave me with some good information to look into on that.
Yeah. We get that call all the time at the Schizophrenia Society, is that, look, this research in the past has said there was none, but they're not taking into consideration that principle I will now for the third time articulate, the balance of THC and CBD. Is that all right?
Yeah.
Okay, thank you.
It's just, I think too, is like the higher contents of THC when we're looking, 80% versus 1%, and often the CBD content is very low, and so
Right. Like such as the skunk.
because there's different effects with different balances of those, and I think that those, when the THC is so disproportionately high, that's where the higher risk for things like psychosis present.
And I'll just go ahead and put this one in, Ace, about synthetic cannabinoids.
I did have a question about that, yes.
Stay away.
Okay, I read from Dr. Ann Crocker, researcher, synthetic cannabinoids may be significantly worse based on new preclinical work showing that they may permanently alter the expression pattern of dopamine receptors as well.
There we go. Okay, I just have a couple more questions here, if that's all right. One of my questions here is actually more of a recontextualization. Someone had mentioned that the lack of research is the main obstacle to legalization. I think that's actually backwards. I think that the lack of research is actually the result of criminalization. I think that's a very backwards way to phrase it and to look at it, and I think that should be addressed, that it's actually the unconstitutional prohibition of cannabis for the last 100 years that has completely annihilated our ability to actually understand this.
We tried to do studies in the 1980s, and Health Canada would not allow it. And even if they would have allowed it, we couldn't get funding to do it. So in fact, there was a policy prohibition because of international treaties that were signed between Canada and other countries. So that's the real issue behind it. And just alluding to your studies from the 1940s, clinical trials didn't mature until the 50s and 60s. And so when you look at data from the 1940s, you have to be very skeptical because you have to look at the size of the study, the control groups, and all the rest of it. And we're getting into statistics. But you have to be really careful because a lot of those researches are anecdotal and they're case series. And you don't know what, and we didn't have the drugs that we have now to treat mental disease. And so the interpretation becomes problematic. I don't think, I think your observation is okay, but the emphasis you're putting on it is problematic. I think we need, if that's true, we need to do that study again, and once it's legalized and fundable, we'll find out the answer. We really don't know the answer right now.
Oh, okie doke. Yeah, I was actually more asking if you guys knew of any studies from, pre-60s era when there was clearly a sharp spike in cannabis use, but it doesn't seem like there was any information.
I just want to, can I make a comment too about research? Typically in Canada, when it comes to any kind of substance, so let alone cannabis, but even medical drugs that are used in the medical domain, we're often a little slower than, for example, the US. The US is a little bit more aggressive, and then we kind of wait until there's more anecdotal information, and then we bring through. So there's also, it's not just unique to that, but that's kind of
a lot of my perspective comes from double PhD Dr. Robert Melmead from the University of Colorado, Colorado Springs.
So we learn a lot from Europe, we learn a lot from US, and then we move forward a little bit more.
I had one question for our constable here. I was just curious about, I had very vaguely looked at the new laws regarding cannabis use and impairment, and you had mentioned a few things like going a bit slower, going a bit faster, like stopping at the wrong distance at a stoplight. And I was just wondering if that's going to be then grounds now to be able to search vehicles, or how that's going to work. Like if you just see somebody you think is going too slow, you can kind of say that's probable cause that they're high, and then you can search their vehicle. Like I know that there's a lot of laws changing in that regards, and I don't really understand that.
No, with respect to search or search and seizure, as we often refer to it, roadside traffic. Without getting into any minutia for some secondary information or anything, essentially it's plain view doctrine is what it's called. So if where the officer's standing, they can see X, Y, or Z, that is that plain view doctrine. As long as the stop is reasonable and the interaction is related to the stop, if there's something else. That's how you can transition from an impaired driving stop to a firearms offense, if that was plain view doctrine, sort of, to use that as an example. Keeping it within the same context, though, with respect to visual indicators, like whether it be bongs or pipes or baggies or that sort of screens, that sort of material.
Okay. Yeah, if you guys are cool, I'll ask another question.
One more.
Only one more?
One more.
Okay. So cannabis prohibition on it and its impact on mental health. We talked a lot about cannabis use and other drugs on as an impacting on mental health, but I was curious as to what research has been done on the actual prohibition and how that has impacted our mental health.
Well, I think from a harm reduction perspective, prohibition leads to black market, and the concerns, of course, with a black market is that we don't know about the safety of those products. And so potentially legalization and removing the black market will actually make for a more safe product. And so I think that's one of the things that can be seen as very positive, that when we look at removing prohibition and creating policy that supports access that's affordable and accessible in safe ways, that may be good from a public health perspective.
Yeah, and kind of showing people that, whatever place in life that they're stuck in, as long as they're not being criminal, stealing or killing someone, or endangering others' lives, that they're actually still part of the human family.
It removes the issue from being a moralistic issue
Yeah.
to being an issue around choice and also making good health decisions and having access to information that supports all of us to make healthy decisions that promote well-being. And that's certainly what we would advocate for.
Great. Thank you guys very much.
Thanks, man. I'll do this next because there are 3 of them. They're worded a tiny bit differently, but they're all different handwriting, so obviously there's an appetite for it. And it's simply, how long does cannabis stay in someone's system?
It depends on how much body fat you have, because actually the termination of cannabis activity of the THC component is by redistribution of the drug to body fat. We had an anesthetic that was like that in the 1950s called thiopental, and it stayed in the body and it got moved back between fat and lean tissue before it was eliminated. And I think that gets around the issue of the argument about whether that you really can't use a blood concentration of THC to declare that impairment is present. We had the same issue with alcohol with the 0.08 and the impairment. They're 2 separate statements, and both can happen or they can happen independently of each other. And so the important question is, because we don't have standardization, so we don't know how strong the THC was. We don't know how long ago it was. We don't know what the dose was. But the conventional wisdom that I understand is up to 6 hours after inhalation, you should assume that you're impaired. And after 6 hours, it's a toss-up. I had a workplace safety issue that I dealt with a month ago, where someone had no access to THC for a month. And they were at an isolated work site. And because they got into an accident on the last day of their work, they had to do a drug screen. And the urine test turned out positive for THC. But there are data from the American Psychiatric Association going back to 1980 where they were able to put people in hospital without their permission for long periods of time and measure quantitatively how long the THC would have exceeded the cutoff level we use right now. And that person had impaired levels in their urine that lasted more than a month. So it's not an easy question. The more obese you are, the longer it's going to stay in your body because it's very lipid soluble.
If I can add to that too, it's not just the adipose tissue, but how much you consume, the route that you consume, and if you're a chronic user. So obviously the more that you're using over time, it's going to stay residual in, if you were to test, for example, a longer period than if you're a one-time user per month, for example. So lots of factors that come into play, and how you consume it. Inhalation will come quicker than if you do ingesting. So different factors that come to play there.
And from our perspective, we govern the same sort of principles. So from a drug recognition expert perspective, 8 to 9 seconds for inhalation. For onset, peak is 10 to 30 minutes. We have that transition phase in that 4 to 6 hour range where the efficacy is certainly decreased. But like workplace as well, There's research that supports up to 24 hours for factors to be considered from consumption. The ingestion, that's considering a smoked. Obviously, if it's ingested to the edibles, even then we talk about all these different permutations and combinations of what affects it. Empty stomach consumption versus already food in the belly, as far as absorption and protracted durations there. So again, that 10 to 30 minutes, 4 to 6 hours, and then that long extended 24 hours. And just to reiterate what Dr. Sitar, the new blood legislation is within 2 hours of the offense for blood, and for sure urine is greater than a month is certainly shows up all the time. So if it's a urine-based test, it does have a very protracted presence in the system.
Just one final point is that edibles are totally unpredictable. It depends on the lipid content, and so the onset definitely is slower. The duration is much less predictable. It can be, depending on your transit time of your gut, it can be prolonged if you have a short transit time because you ate at the wrong restaurant. It might be, you might have less impairment than you had otherwise.
And that's actually a very important issue from the impaired driving perspective. I know edibles from a government perspective are a long way out, but there's been some creative kitchen cooking for a long time. And what happens with the consumption of edibles is that the impairing result is not there yet. So we have more, and then we have more, and then we have some more, and then suddenly it's all there at once. And you know, we end up with this upward curve for onset and duration.
All right, we will head to the mic. It's all you.
Thanks, everybody. Yeah, again, thanks for coming out. I really appreciate this. It's been a informative, interesting evening. Personally, I'm Steven Stairs. I don't know if some of you know me here. I got a little cheering crowd over there. I'm the local cannabis advocate guy, the guy that comes to these kind of things and asks tough, hard-hitting questions, so don't be shocked. I just really have one specific question, and this is just from the medical patient kind of standpoint. And this is directed for you, Constable English. The new bills that the provincial government came out with, Bill 25, Bill 11, and Bill 26, I guess I could have done that in a better order. The Bill 25 and Bill 26 are the ones that relate to public smoking and Highway Transportation Act amendments and things like that. Bill 11 is about retail sales and things like that, and you know, who can sell it and how much, and et cetera. Bill 11 has a caveat inside of where the exemptions, right in the headings. It's about 3 paragraphs. It basically outlines that there's exemptions made for medical cannabis users to consume in public. So just in case any of you guys didn't know that, medical patients can still consume in public. So, or they can when the bill comes into effect. They can now anyway. So what I'm concerned about, though, is that the Bill 25 and Bill 26 don't have those exemptions. I presented myself at committee hearings at the legislative building asking the Justice and Health Ministers and the committee regarding this bill if they would put that amendment in. They chose not to. They passed the bill in June. So now that goes to the enforcement of that bill. On that note, Constable, what will you do if you or someone you've trained in this field pulls over a medical cannabis patient who hasn't shown any signs of impairment? They're not slowing down, they're not blinking when they're not supposed to be turning, and they haven't showed any driving aspects of being impaired. And you pull them over for just a random roadside test during a check stop, like you mentioned. They fail the saliva test, but they don't fail any other test. They're not impaired, but they've failed the nanogram limit. What do you do?
So just a couple points of clarification. So if you were to use the check stop as your example, if you come to a check stop, the new legislation is going to have alcohol screening that doesn't have reasonable suspicion. Alcohol screening will be a de facto capability. Drugs is not. So drugs is still a reasonable suspicion. So if, as you said, you drive in and you're not showing any symptomology, no driving behavior that causes anybody any suspicion, then the grounds wouldn't be formed. And so it wouldn't matter recreational or medicinal at that point. If you're not displaying those behaviors, then the reasonable suspicion wouldn't, I guess by admission, you could do a roadside screening device. And again, there is no nanograms there as far as displayed values. It's just present or not present.
Pass or fail, right.
Yeah.
Okay, so on that note, what if they are driving a little slower, but maybe they always drive that slow? What if they, you talked about the red eye thing, that's a good one, glaucoma, blind guy. I don't actually drive, this is really more about other people's, and this is what advocacy is about. So what if they aren't? They blinked, too fast, or I can't even describe this because I don't drive. What if they put their turn signal on too soon and they just left it on? That could have just been I was changing the radio, kind of forgot what I was doing, or they could be high. Again, what if they're a medical patient? What do you do?
Well, driving...
There's no protections in the law for medical patients. That's why I'm asking this.
Yeah.
It's up to you guys to protect medical patients.
Well, and so when you say protect medical patients, that's the definitive difference. It's illegal for anybody to operate a motor vehicle while they're impaired by a drug.
Correct.
If you're impaired, no one in society wants you behind the wheel.
Agreed.
And that includes yourself, I would hope. You may have...
we were in the same Winnipeg Sun article today, and I did say that.
Oh, you're my compadre there.
If I
Okay,
can
nice
add
to meet you.
And medications. So that applies, so for example, if we prescribe medications outside of cannabis, if that we always give, as a physician, we'll give that knowledge to the patient. Please don't drive while we're, right?
And that's what I mean truly by drug, because, and we go back to the geriatric population, that accidental impaired. No one had the intent to consume and drive. It's the sum of the pill bottles in front of them that unknowingly snuck up on them, and now they're not aware of the difference in their driving ability. And we certainly run into that as well. So again, medical, recreational, impaired behind the wheel, visibly impaired, to cause a subject stop like that would be the same practice. And when you said about leaving the blinker on, that's certainly an indicia of, that's one of the things, but it's not the single entity. It would be a summation of behaviors. If an officer's following a vehicle, it's the weaving in the lane, it's the changing in the speed, it's observation for you have to have enough to observe to say, I'm concerned. You don't want it to go protracted to the point where someone could potentially cause an accident as well, though. So it's never just a single indicator. And then after the stop, there's interaction between the officer and the driver that will then either verify their suspicion or make them realize it was a radio knob or drop something on the floor, et cetera, like that.
Thank you.
Thank you, man. There's two, again, sort of versions of this question, so obviously it should be answered. Does the likelihood of psychosis increase the longer, and then someone else said more frequently, you use cannabis? So does the likelihood of psychosis increase the longer or more the more you use cannabis in terms of frequency?
Yeah, Dr. Phil Thibault and Dr. Ann Crocker with the Halifax Health Authority, their studies and review indicate that the use of cannabis can worsen psychosis if you have psychosis, and can lead to a longer term of psychosis once it develops. All again on those factors around age, potency, frequency, etc. Does that sort of answer the question, Ace?
Yeah, it was.
What we say is avoid.
Does the likelihood of psychosis increase the more you use, basically?
Yes, yeah, but based on other predispositional factors within the individual. But what psychiatry is going to be saying, and CAMH, Center for Addictions and Mental Health, they're taking an abstinence position. They're a little stronger than our website. In fact, the Center for Addictions and Mental Health, the largest mental health hospital in Canada, actually did not want us to reference them on our website because they've taken a strict abstinence position. I'm not saying they're right or wrong. I'm just pointing out even within psychiatry, there's some various viewpoint. But most would say if you have psychosis or a mental illness, it's best to, it's quote best, wisdom best to avoid alcohol and hallucinogenic substances. Or if you do, moderation at the least, then who determines moderation? Anyway.
Can I just say something around that? Because as a person who's been a mental health clinician supporting individuals who've been diagnosed with psychosis or schizophrenia, I worked in the early psychosis intervention program and supported that team. I've worked in programs for sort of community treatment, assisting people with significant struggles around psychosis and schizophrenia who use cannabis. And part of the work that I did with them was to help them understand the connection to their use and their symptoms. And that's based on a harm reduction approach, but also a process of growth and development. So if you're struggling with something that's not, like you don't like psychotic symptoms, understanding what triggers that, whether that's, stress or your diet or other factors, is an important part of your recovery journey. And so I think we can talk about these issues at a macro level and talk about what the policy is, what the research tells us, but at the individual level, it requires relationships and understanding the connection between my health and well-being and the things that are happening in my life, and how do I want my life to look, and how do I get support to help me on that journey.
And let me just affirm how Marianne just answered that question somewhat differently from me. We practice at the Schizophrenia Society how she said it. She just said it better than I did. Okay? So I don't, I mean, because, no, it was beautiful. Thank you.
Thanks. Let's head back to the floor right now. It's all you, my man.
I want to thank you for the discussion and your time up here. And your discussion has led to some questions that I just want some clarification on. And I came up with a difference than this last one. But from this last discussion, I'm wondering, is there evidence that the cannabis use is causing psychosis and schizophrenia? Or is it just triggering it in someone or exacerbating it in somebody?
That's a good question.
And is there data that shows longitudinally? Because I know Dr. Jeanette, I believe, you had showed data of usage over time. Do we see psychosis and schizophrenia levels going up and down with cannabis use over time? Because there was quite a bit of variation over the decades, and so we should be able to see correlations with increased levels of schizophrenia and psychosis as well.
Well, I think like any research, there's studies out there that can be, zeroed in on that will tell you one thing, and another study that if you look at it, it tells you something different. And so that's, I think, the point here tonight is that there is research, and it's telling us a little bit of information about the impact of cannabis on psychosis and mental illness and many other things. But there's still a need to grow that research body so that we can really truly understand the trends and the effects. I've certainly read articles where it says that cannabis for some people can be a switch, and there can be a switch that then triggers psychosis. But that's the dilemma between sort of the research that there's, is it causal? Does it have an effect? So I think, it's still an emerging area. There's more refined thinking, but it's still emerging.
So I'll just read. The reason adults over 25 are not at the same risk as adolescents is that these cannabinoid receptors change their expression pattern at the end of brain development from primarily expression on white matter to primarily expression on gray matter.
Right, and that's good data, and that would imply that the data that Dr. Jeanette showed, that showed the huge variation across time, we should also see huge variation in schizophrenia levels across time as well to see if it is actually causing it or just exacerbating it in those that are there. So maybe we just open, we'll leave that there.
Well, it's known that regardless of the issue of cannabis, psychosis affects 3% of the population. Schizophrenia, a manifestation of psychosis, is 1% of the population. That primarily happens in adolescence and emerging adulthood, psychosis and schizophrenia. It's not to say that a 45-year-old man can't develop psychosis or schizophrenia, but it's primarily an adolescent, emerging adult condition.
Which also have the highest uses of cannabis.
Maybe if I can add to that, psychosis can present under various contexts. So it can present with infections, it can present with many different substances. Lots of times with cannabis, and I'm not an expert of schizophrenia, but what I will say is often when there's dose-dependent effects, meaning that the higher the potency, usually the higher the risk. So sometimes there's that component as well, meaning that lots of times the higher the percentage of the THC, then there might be more risk for the psychosis.
Right. The other question, I guess, goes to the Constable. In a past life, I was a professor and did medical policy and statistics and research, and quite astounded when I moved from psychology to that area to look at some of the reliability of the indicators you're using for medical tests. And I'm just wondering, when we look at introducing laws that have such a big impact on our community, what kind of evidence is there for reliability, specificity, and sensitivity for these kind of behavioral indicators and blood tests and things? Do you know if we actually have data to be making these kinds of decisions?
So the blood is very new to all of us, and I would not be comfortable answering anything related to that. You know, we in law enforcement, we rely on our policymakers and our legislators and our elected officials. They're the ones that you know, go through that process and come up with an output that becomes enforceable at that point. From the rest of the indicators, the non-clinical or non-biological, I say non-clinical, the non-biological, both clinical and psychophysical, those indicators have been researched since the late 70s. In the States, they have NHTSA, the National Highway Traffic Safety Administration. They sort of pioneered the whole standardized testing route, and it's been through several batteries of validation and court affirmation, clinical, both physician and law enforcement roadside practice, and have been, you know, sort of honed and finalized many, many years ago, and subsequently even the DRE process recognized by the Supreme Court of Canada very recently as the 12 steps of sort of being, not irrefutable is not the right word, but if they're a solid evidence-based implementation of roadside signs and clinical indicators. It's the biology or the blood that is certainly new to our system. It's new to all of us. Blood has always existed by way of a warrant, but law enforcement interaction with that is simply obtaining the warrant, obtaining the blood, and then it goes to lab for extraction and extrapolation. And that's the RCMP. And nothing will change with respect to the new impaired blood rules. It will still go to the RCMP for extrapolation.
Okay, thank you. So there would be data on, you know, just how many false alarms and false positives and things these tests might be having.
I would assume, given the number of stats in the world, that somebody's got
somebody
that.
should have that data.
Yeah, it's not something I'm read in on, sorry.
Yeah. And I guess related to that is, for the doctor second from the right there, whether you know, in this conversation, it wasn't clear to me if I was following properly, but what is the correlation between blood levels and actual impairment? Do we know what that number is?
For THC?
Yeah. Or whatever indicator the Constable is going to be using.
It depends on the time of ingestion and the route of ingestion. So as I think you heard earlier, if you smoke it, the onset is less than a minute usually, depending on your lung function. If you take it orally as cookies or brownies or whatever, the onset is unpredictable. The duration oftentimes is erratic because people are waiting for an effect that hasn't started yet, so they keep ingesting. And so suddenly they have a higher dose than they thought they had.
Well, so that's the relationship between ingestion and blood levels.
Yes.
But I'm actually concerned about the relationship
The blood
between
level
blood
itself,
levels.
the blood level itself is not, cannot stand alone.
For
The brain
impair-
level
for
is-
impairment.
The brain level is what happens. Alcohol is the same thing. That when you're drinking alcohol, when the concentration is rising, you can show signs of impairment at a lower concentration than when the alcohol concentration is falling. So in and of itself, the alcohol concentration is not absolute unless you know the history of drinking around the time of the alcohol. And that's why, I'm not a lawyer, but I understand that's why the legal system passed the statute in two parts, where they said an absolute 0.08, and in some parts of the country it's 0.05, and in some places in the world it's 0.1, but there is a level at which they disregard whether there are signs of impairment or not. And there is an impairment statute that disregards what the concentration is. Oftentimes they go together, but in an alcoholic, there are case reports in the literature of people with blood alcohols of 600 milligrams percent that function as well as you or I do, but those are people with huge alcohol dependency problems. And so you can't go by the concentration alone and infer impairment. And so I think with THC, we're seeing the same issue, that the government, in its wisdom, has decided to set a blood cutoff level regardless of signs of impairment. And they've also set an impairment indicia that the police are trained to take over and look at function in and of itself without looking at the blood level. And if you see impairment and then you take a blood sample and they agree, you're okay. But for example, if you see impairment, and I'm going to the extreme here, and you're a diabetic who's going hypoglycemic, you may have no alcohol in your blood, and it's the hypoglycemia due to your diabetic state that's causing your impairment. And then we get into a really difficult issue about whether this is a criminal offense or not. And we're getting into philosophy, and I don't think we have enough hours in the night to discuss that one.
Right.
Speaking of, we have, can you be super quick?
It's just a clarification that if I understand what he's saying, then is that we're actually, are we going to be fairly objective in our assessments of impairment, or is it still pretty subjective for THC levels?
You're talking about roadside, like for
Yeah.
law enforcement? You know, as Dr. Sidar just said, the reason that two separate offenses exist in the code is just for that very thing we've just talked about.
And that's in the THC code as well, then?
Yeah, it's just an expansion of the criminal code. Yeah, it's the 253 section for impaired. Impaired is impaired, functionally unable. And you know, to bring it to something that we're a little bit more familiar with in the alcohol perspective, we know that 50 is a warrant, 80 is criminal per se, they call it, a per se limit. The criminal code says you're impaired regardless of the behavior you demonstrate. We run alcohol labs with volunteer subjects while we do the training, and we dose them into a range so that the behaviors can be exhibited. And we've had people as low as like high 30s of BAC be functionally impaired, but nowhere near the per se limits. So.
Okay. Thank you very much.
Thank you. Okay, last word to you. I don't want to put pressure on anyone, but whoever has the best and shortest answer wins the panel.
This is more for the police, sir. Will you please be able to differentiate CBD, smoking CBD only, and or THC? CBD will have a little bit of THC in it, of 0.03, but if you do the roadside test, it will show that you have THC in you, but you're not impaired at all.
Yeah, I'm not discounting your question, but I think the short version is the same thing. Impairment is impairment. So if there's a reason to assume that the person's impaired, we'll go down the impaired path. If that leads to a confirmation by a device that's been designed to register THC, that will show up as a positive if there's THC as a contributing factor. But again, it's reasonable suspicion needs to lead to that in the very first place. So, I think if I understand some of the questioning and the arbitrary driving down the road, if you're not impaired, you're not impaired.
I'll use me for an example. I have PTSD. So during the day when I know I'm driving, I'll take CBD only. Now, if I'm outside and I'm smoking, I join the CBD and a police officer sees me, that is, he has grounds to presume I have THC. Now, if I do the testing, it'll show I have THC, but in reality, I don't. So that's what I'm questioning is, showing my prescription, would that suffice to explaining to him that, this is only CBD, or would I have to go to court and explain myself in court for that?
Well, when you said outside, that would be Bill 25. That wouldn't be criminal code. So it would be simply a ticket. So there would be no arrest or a roadside screening device or anything for just being in a public place or in your yard smoking at that point. So I'm not
Unless he sees me get into my vehicle and drive off.
Yeah. Again, if he sees you get into your vehicle because you're smoking, in an officer in a car, are they going to be able to tell that you're smoking something that's THC based at your own premise, vice just smoking a cigarette? I can't speak to the equations there, but the laws are clear to reinforce. It's reasonable suspicion against impaired driving. And so just simple consumption, and we talked about the tolerance. If it's as frequent as you said, you may very well be in a tolerant state where you don't exhibit any signs of impairment at all for low dose, frequent use like that.
Thank you. And we've gone a little bit past, but I want to thank, your questions were awesome. And there's some, I know we didn't get to some, and there's some, but these people, I don't want to speak for them, but this is what they do, and there are resources that can answer your questions, or if you want to contact the organizations that our panel is representing, they will happily answer your questions. So to all of you who came this evening, thank you for sharing the evening with us. To our wonderful panel, thank you. Please give them a big round of applause. And again, so all of this, if you missed something or you want to show it, so they'll put all that on the Manitoba Schizophrenia Society website, so you can review. And any other loose ends? Did I miss anything? We're good? Okay, thank you all for being here. And again, to the panel, thanks so much for sharing your time with us. We appreciate it. Have a good summer if I don't see you.
Yeah, I'd just like to say the same thing. Thank you so much for coming out and supporting this event. And thank you to our panel who actually came together within 2 weeks. Like that's the length of time. And well, Jeanette, much shorter.
2 minutes.
Yes. Jeanette heard about this yesterday. Last night and came. Yeah. And so thank you very, very much. And thank you to Ace for emceeing.